Hi everyone, this lecture is going to cover the spine and posture. This is chapter 14 from your book, and this is the first in several lectures that we're going to cover the spine. So just again as a quick anatomy review, the spine is made up of 33 total vertebrae. We have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 fused sacral, and then 3 to 4 coccygeal. So you can see those depicted in the picture over here. The spine is going to articulate with the occipital atlas joint at the head and skull. It articulates with all of the 12 ribs, and then it also articulates with the SI joint in the lower part. Every joint of the spine or on the vertebrae are comprised or made up of 2 zygapophyseal or facet joints and an intervertebral disc. And you can also see in this picture here, just as a review again, the different sort of shapes of the vertebral bodies as you go from cervical to thoracic to lumbar spine. The major motions of the spine are going to be flexion and extension. This is a picture directly from your book, so it's showing you how the vertebrae are moving on each other for each of these motions. B shows side bending, C is showing rotation, D is showing anterior to posterior shear, E is showing lateral shear, and then F is compression or distraction. And that is what we are doing when we think about tractioning the spine. We're trying to distract the vertebrae from one another. Very important part of the spine is the intervertebral disc, made up of the annulus fibrosus and the nucleus pulposus. The annulus is going to be the outer portion. It's made of very strong collagen fibers, helps to provide tensile strength to the disc, helps to contain the nucleus pulposus. It does limit spinal motions. It acts as a ligament connecting one vertebrae to the next, and it is supported by the anterior and posterior longitudinal ligaments. The nucleus pulposus is the middle portion of the disc. It's a gelatin type material. In the lumbar spine, it is located a little bit more to the posterior aspect of the vertebrae, and the main job of the disc is to distribute pressure from one disc to the next. It is a shock absorber, and it's the fluid dynamics that help maintain nutrition of the disc. Fluid dynamics is talking about imbibing fluid in the disc, and when there is no pressure on the spine, the discs tend to take in more fluid, and then when the spine is compressed or loaded, it tends to release some of that fluid. So normal postural alignment, we have 2 posterior curves, 2 anterior curves in the spine. The posterior curves are the thoracic and the sacral areas, and they are typically termed kyphosis. The anterior curves are going to be your cervical and your lumbar curves. They are lordotic curves or lordosis. And with proper posture, if you take a plumb line and drop it, it should fall right through the center of the external auditory meatus, just anterior to the atlanto-occipital joint, through the cervical and lumbar vertebrae, to the middle or slightly behind the hip joint, and then just anterior to the knee and the ankle joint. So you can see that in the picture over here as well. So major muscles of the lumbar spine. We have the abdominal muscles, rectus abdominis, internal and external obliques. Those are going to be our major trunk flexors. They're going to help respond to any type of postural perturbation. Another abdominal muscle is the transversus abdominis. We talk about this one by itself because it does have a pretty major role in maintenance of posture. It is the deepest abdominal muscle, and it actually sort of wraps around the whole abdomen. It is really important for core stabilization, so you've probably heard of different ways to train the transversus abdominis, possibly what we call the drawing in maneuver, which may also be abbreviated ADIM, abdominal drawing in maneuver. Later on in this lecture, I will have a link for a video that shows a couple ways you can instruct patients in this exercise. But this is a really, really common exercise to be used when we talk about core stabilization. And the reason it's so important and we train it a lot is because if it is trained properly, it has been shown to improve outcomes in patients who have low back pain. So it can help to reduce their pain, help them have better functional outcomes. On the flip side, we have the erector spinae group, or ESGs. They help, or they perform trunk extension. They run the entire length of the spinal column. They also respond to postural perturbations. And then we also have the multifidus muscles. These are smaller muscles They are type 1 tonic stabilizers. These run from vertebrae to vertebrae, whereas your erector spinae are going to span long groups and again run the whole length of the spine. Your multifidus are in between each individual vertebrae throughout the spine. They have found that in patients who have chronic low back pain that these little muscles do tend to atrophy relatively quickly. So we will eventually talk about some ways that we can strengthen multifidus or multifidi muscles as well. So moving up to the cervical spine, the muscles that are major players up here are going to be our mandibular elevators, so the masseter, the temporalis, and the medial pterygoid muscle, basically helping to maintain the resting position of the mandible. We have the supra and the infrahyoid, which assist with swallowing and balancing the jaw against those muscles of mastication. And the big thing with those, and the reason we mention those, is because they can get stretched and weak with a forward head posture. So as we get further into this lecture, we're going to talk about some of those fairly common postural deviations. Forward head is one of them. And then with that, we're going to see some issues in the cervical spine involving some of these muscles. In the cervical spine, we also have rectus capitis, longus colli, and longus capitis. Those are deep flexors that are going to provide dynamic support. And then we also have multifidus muscles in the cervical spine, similar to the lumbar spine. So the book talks about some postural pain syndromes and gives some different definitions for each of these terms. So a patient can have a postural fault, which is a posture that's going to deviate from normal, but there's no structural impairment. So this is a reversible issue where we can simply move them out of that position. Postural pain syndrome is now pain from mechanical stress due to prolonged maintenance of a faulty posture. There is pain now associated with it, whereas just a postural fault doesn't necessarily have pain associated with it. Getting into postural pain syndromes, there is some pain, but it's usually relieved with activity. So once the person gets out of that faulty posture, the pain generally tends to go away. There are no impairments with strength or flexibility yet, but if that person continues to maintain that faulty posture, they will develop over time. And then what that turns into is the next one, your postural dysfunction. So this is actual adaptive shortening and muscle weakness that develops from this long-term maintenance of faulty posture. So poor posture, it could also be due to trauma or surgery, either to the spine itself or to an area where now we have a compensation with the spine. With postural dysfunctions, these people may be predisposed to injury or overuse syndromes because of the alignment of the spine now. And so that is why it's important to teach our patients good postural habits. We want to start with kids, teaching our kids good postural habits so they don't develop faulty postures as they age, getting into the workstations of our patients and to make sure that they have a good working environment, looking at the recreational activities. What are they doing? Are they maintaining or able to maintain good postures throughout their activity? We may also need to incorporate flexibility and posture training after trauma or surgery, again, depending on if the person develops any postural faults because of that. So we're going to talk about some of the common faulty postures that you will see. So in this picture, you can kind of see what an ideal posture is going to look like. The first one we're going to talk about is this kyphosis lordosis. It's basically just an exaggeration of both of those curves. We will talk about an increased lumbar lordosis, swayback, which is an increased thoracic kyphosis, as well as a flat back posture as well. So again, the first one is the lordotic posture, which is an increase in the lumbar lordosis, which puts the pelvis into an anteriorly tilted position, which you can see in this picture here. With that increase in the lordosis, the pelvis is going to come anteriorly then. This is often seen with an increase in the thoracic curve as well. So you see an increased lordosis and you also see an increased thoracic kyphosis as well. Forward head is also a common or often accompanies this posture as well. So the impairments of the muscles that we're going to see tightness in the hip flexors as well as the lumbar extensors. So hip flexors, we're talking about iliopsoas, tensor fascia latae, and rectus femoris. The lumbar extensors, we're talking about our erector spinae group again. So when those muscles are tight, then we're going to have stretched muscles on the opposite side. So the abdominal muscles are going to be stretched and therefore weak. So the rectus abdominis, internal obliques, external obliques, and transversus abdominis, as well as the hip extensors. And here we're talking about the hamstrings and glute max. Those are going to be stretched and weak. So potential sources of symptoms could be stress to the anterior longitudinal ligament, because as you can see in this picture here, when we increase the lordosis, we're going to stress or stretch out the anterior longitudinal ligament. Narrowing of the posterior disc space and the intervertebral foramen, so that can then impinge on blood vessels and nerve roots. And then we also have an approximation of the facet joints in the lumbar spine, which can then accelerate degenerative changes of those. So this is a slouched posture or swayback, and so you can see it's going to typically result in a forward head and an increase in the thoracic kyphosis. There may also be a slight increase in the lumbar lordosis as well, but the big thing that we see here is that the whole entire pelvis is just shifted forward, which is going to result in some hip extension. Okay, so this is what we call a swayback posture. Again, it is often accompanied by forward head. Again, what we expect to see tight here are going to be the upper abdominal muscles, the intercostal muscles, and the hip extensor muscles. What is going to be stretched and then weak are going to be the lower abdominal muscles, the extenders of the lower thoracic spine, and hip flexors. So the reason it's important to know these things too, because when it gets to treatment of these postural syndromes, it's really not rocket science, but when we have these poor postures and we have tightness of muscles, we need to stretch those muscles out. Because when those muscles get tight, then that just further helps to maintain those faulty postures. And then we also need to strengthen then what has become weak. Because if these muscles aren't strong enough, the person isn't going to be able to maintain a normal posture. So as we go through these, it is important to know what's going to be tight, what's going to be stretched and weak, so that we can properly treat these patients. Potential sources of symptoms here are going to be stress to the iliofemoral ligament because they're basically standing in hip extension. Most of the time, the iliofemoral ligament is going to be stretched and strained, as well as the anterior longitudinal ligament and posterior longitudinal ligament, respectively, in the spine there. We also expect to see narrowing of the intervertebral foramen, which can, again, compress the blood vessels and the nerves that exit through there, and approximation of the facet joints, which can accelerate degeneration in those areas. A flat low back posture is going to basically be the opposite of an increased lordosis. We're going to have a decrease in the lumbar lordosis here. We're going to have a posterior pelvic tilt with this impairment. So the muscles that we expect to be tight are going to be your trunk flexors or your abdominal muscles and your hip extensors. We will expect to see stretched and weak muscles in your lumbar extensors, so your erector spinae, and your hip flexors. Your potential sources of symptoms here, because of this decreased lordosis in the low back, that can lead to decreased shock absorption of the lumbar spine, which can then predispose the lumbar spine to injury. It can stress the posterior longitudinal ligament. It'll also increase the posterior disc space. Now we're opening up the disc space in the back, more space between the vertebrae. Because of this, the nucleus can now actually imbibe more fluid than usual, which can increase its chance of rupturing, just like we talked about in modalities. The most common cause of this posture is just habitual slouching. The rounded back and shoulders and forward head posture, we've mentioned this a lot, rounded shoulders, forward head. We see this a lot with patients who sit for long periods of time. So we expect to see an increase in the thoracic kyphosis, protracted scapula, and forward head, which means a flexed lower cervical spine and extended upper cervical spine. And we extend the upper cervical spine so we're not just staring at the floor the whole time. So what we expect to be tight in people who have forward head and rounded shoulders are going to be pec major and minor, the lats, serratus anterior, the levator scapula, sternocleidomastoid, the scalenes, upper traps, and suboccipitals. What we expect to be stretched and weak will be the rhomboids, the middle and the lower traps, supra and infrahyoids, as well as the capital flexors. Common causes of this are going to be just the effects of gravity, again, poor ergonomics, and habitual slouching. So potential sources of symptoms. I had to make this one its whole own slide because there's a lot. So we can see stress to the anterior longitudinal ligament in the upper cervical spine and the posterior longitudinal ligament in the lower cervical spine and the thoracic spine, fatigue of the thoracic erector spinae and scap retractors, irritation of the facet joints in the upper cervical spine, narrowing of the intervertebral foramen in the upper cervical spine, which again can impinge on the blood vessels and the nerve roots, impingement of the neurovascular bundle from the anterior scalene or pec minor tightness, which can lead to thoracic outlet syndrome, impingement of the cervical plexus from levator scap tightness, impingement of the greater occipital nerve from upper trap tightness, which can lead then to tension headaches. We can see TMJ pain, again, because of the malalignment of the jaw with the forward head, and lower cervical disc lesions as well. So that is quite an extensive list. The last one is the flat upper back and neck posture. This is sometimes described as sort of an exaggerated military posture, so this one is not common. This is actually going towards the opposite end of the slouched posture, right? This is kind of like an overcorrection of posture. So with this, we see a decrease in the thoracic kyphosis, depressed scapula, depressed clavicles, and a decreased cervical lordosis. So what we expect to see tight are the anterior muscles in the neck, the thoracic erector spinae, and the scapular retractors. What is going to be stretched and weak are going to be your scapular protractors and your intercostals, which could potentially lead to some scapular issues and some shoulder mobility issues. So potential sources of symptoms are going to be fatigue of the postural muscles because they're constantly working to hold that position. Compression of the neurovascular bundle in the thoracic outlet between the clavicle and ribs, so again, development of thoracic outlet syndrome, TMJ pain, and then decreased shock absorption because of the lack of lordosis in the cervical spine, which can predispose it to injury. All right, so those are more of like your increased curves and poor posture. Now I want to talk a little bit about scoliosis. This is a different curve in the spine. This is more of that lateral curvature of the spine, typically in the thoracic or the lumbar areas of the spine. It can also be associated with asymmetries of the hip, pelvis, and lower extremities. A structural scoliosis is an irreversible lateral curve with fixed rotation of the vertebrae. So the vertebrae are going to be rotated toward the convex side of the curve. And so because of that, they're going to rotate towards, this is the convex side of this curve. This would be the concave side over here. The vertebrae are going to rotate towards the convex side. And so with that, the ribs are going to move. And so there's going to be sort of a posterior rib hump on the convex side, and the ribs will be more prominent anteriorly on the concave side. This is what they check for, like in gym class, when you're checking for scoliosis and they have you bend down forward towards your toes. What they're looking for is for your back to be even. If one side appears higher than the other, then that could mean a potential rotation of the spine or scoliosis. A non-structural, which is also known as a functional scoliosis or a postural scoliosis, this is a reversible curve that can be changed with either changing the patient's position or correcting one of the contributing factors, which would be things like a leg length discrepancy, pelvic rotation, or some sort of asymmetry of the lower extremity, which we're going to get into in just a minute here. So potential impairments that we can see with scoliosis, we can see tightness of muscles, joints, and fascia on the concave side. That's the side that's kind of they curve towards. So everything's going to be kind of tight on that side. And then we're going to have weakness on the convex side because everything's being stretched out on that side. If one hip is going to be adducted, the adductors on that side will be tight, and then the abductors will be stretched and weak. The opposite will then occur on the contralateral lower extremity. And we'll see this because you will often see pelvic asymmetries along with the scoliosis. With really advanced scoliosis, you can start to see decrease in rib expansion and cardiopulmonary impairments, which can actually eventually make it difficult to breathe. So when it starts impacting major functions like that, patients will often have surgery to correct their scoliosis. Potential sources of symptoms with scoliosis can be muscle fatigue and ligament strain on the convex side, nerve root irritation on the concave side where they're being kind of impinged there, and joint irritation from approximation on the concave side. Again, so the facet joints are being pushed together closer on that side. So common causes of scoliosis: structural scoliosis can come from things like neuromuscular diseases, spinal cord injuries, osteopathic disorders, or idiopathic causes where we just don't know why it develops in some people. Functional scoliosis can be caused from leg length discrepancies, which can have a bunch of causes in and of itself, muscle guarding or spasms on one side of the spine, or habitual or asymmetrical postures. So lower extremity asymmetries. So some of the deviations that we're going to see with this. So here in this picture, you can see this is coming from basically an overpronation of this ankle here. And so that is basically essentially creating a leg length discrepancy with this person. So we're going to talk about long leg side and short leg side in some of these deviations, and that's what these abbreviations mean. So on the long leg side, that hip is going to be held in adduction, and the short leg side, the hip is going to be held in a moment of abduction. The SI joint on the long leg side is going to have more vertical, or it's going to be more vertical, which is going to create more of a shear force on that. And then on the short leg side, it's going to be more horizontal than it should be, which will actually compress the SI a little bit more. So we can have an increase in SI joint pain in someone who has lower extremity asymmetries. The lumbar spine is going to bend toward the long leg side. The long leg is going to be the one that contacts the ground the easiest. And so that's going to kind of push the hip up a little bit. And in order to keep upright, the person's going to actually lean a little bit towards that side. So that's going to create almost a scoliosis. It's going to create a lateral curve in their spine. So that can compress the discs then on the long leg side. The lumbar facets are going to be extended and compressed on the long leg side, which can then lead to narrowing of the intervertebral foramina, which again can compress the blood vessels and the nerves that exit through there. And again, we'll see a compensatory scoliosis in the thoracic and possibly cervical spine as well. This would be a functional or non-structural type scoliosis. So if we can fix the leg length discrepancy or the asymmetry of the lower extremity, we should be able to fix that scoliosis as well. So the muscle impairments that we expect to see tightness on the long leg side of the hip adductors, and then the abductors on the short leg side. Iliopsoas, quadratus lumborum, piriformis, erector spinae, and multifidus on the long leg side, which is going to be the concave side of your curvature because we're leaning towards that leg. We expect to see weakness because of stretch of the hip adductors on the short leg side and the hip abductors on the long leg side, and as well as all the muscles on the convex side of the curvature in the spine. So that's going to lead to potential sources of symptoms. Again, as I mentioned, the shear forces are going to be changed on the SI joint, so that can lead to degenerative changes and the person can complain of SI pain. We could have narrowing of the intervertebral foramen, which can compress on nerve roots and blood vessels. Lumbar facet joints are going to be compressed, which can cause increased degeneration as well as pain there. We can have uneven wearing of the intervertebral disc, which can cause it to break down faster. Muscle tension, fatigue, or spasm in response to the length and strength relationships, and lower extremity overuse syndromes. So again, common causes can be any type of structural deviation at the hip, knee, ankle, or foot. And in that previous picture, like I showed you, a unilateral flat foot can cause a lot of these changes. So management of impaired posture, what are we going to do? We need to develop an awareness and control of spinal posture in our patients. So we'll get into what some of those exercises are going to be. We need to educate the patient about that relationship of the faulty posture to why they're having their symptoms. So explain to them, look, this is what's going on with your posture. This is what we're seeing. These are some of the potential causes. You can use a spine model to show them what's happening. And then we need to increase the mobility in the restricted muscle, joints, and fascia. So anything that's tight, we need to work on range of motion and stretching in order to get back all of that mobility. And then we need to strengthen or develop neuromuscular control and endurance in the postural and other muscles that have become weakened because of the position that they're in. We need to teach our patients safe body mechanics. We need to do an ergonomic assessment of their home, work, and recreational environment. Anywhere they're spending a great deal of time, we need to make sure that it's set up properly for them. We should be able to teach them some stress management and relaxation techniques, or at least have them look into those to try to help with maintaining normal posture. We all know a lot of times you get stressed, you start to tense up in your shoulders, and that tends to round your shoulders. So again, if we can teach some relaxation techniques or ways to deal with stress so that we don't have that as often, we can hopefully help to relieve some of their symptoms as well. Identify some safe aerobic activities. Again, aerobic activity has been shown to help with all sorts of pain. So spinal pain is definitely one of those things it can help with. So we just have to find the type of aerobic activity that your patient can tolerate without increasing or exacerbating any of their symptoms. We also want to promote healthy exercise habits, again, for safe maintenance. So we want to be able to teach them core stabilization type exercises, teach them safe aerobic activities that they can do, again, so that they can continue to hopefully follow along that path and they won't have reoccurrences of this pain. So posture training techniques, again, the bottom line is, I've mentioned this, stretch what's tight, strengthen what's weak. So we just went through lists for every type of posture that you might see. Lists of what's tight and what's weak. So stretch what's tight, strengthen what's weak. Use verbal cues, tactile cues, visual cues, and reinforcement for your patients to teach them proper exercise technique. And again, this here is just showing proper ergonomic assessment of a workstation, so include that as well. So here are some common postural exercises. These are super common, so I've included links for most of these to some videos. So if you're not familiar with these exercises, take a look at them, because at some point I guarantee you're going to see patients with these postural deviations and you're going to be teaching them these exercises. So for the cervical spine, or really just for any type of poor posture, we'll do a lot of cervical retraction or chin tucks. We do a lot of scapular retraction, shoulder external rotation, because again, with that rounded shoulder position, that tends to put the shoulders in an internally rotated position. So we need to strengthen the external rotators just to be able to maintain neutral. Pelvic tilting and finding the neutral spine. So again, if we have someone who's demonstrating an increased anterior pelvic tilt, we want to work on posterior pelvic tilting. If they're already in a posterior pelvic tilt, we want to work on some anterior tilting. But the bottom line is we want to be able to find a neutral spine. They should be in a neutral position. We'll do lots and lots of lumbar stabilization. I found a pretty good video on transversus abdominis training. So you'll see lots, and these exercises are called like a bajillion different things. So you're going to see all sorts of names for these exercises in the clinic. But I do want you to keep in mind, training transversus abdominis is different than pelvic tilting. A lot of times we see these interchanged, but they are really two separate things. We oftentimes want to do some hip abductor strengthening. So we've gone over some of that with the hip. And then education on body mechanics. I've also listed over here some common stretches that you're going to see. So stretching the suboccipitals, levator scap, the pecs, the lats, lumbar and hip extensors, the lumbar flexors, hip flexors, piriformis, hamstrings. So again, we need to identify what is tight in our patient, and is that contributing to this faulty posture? And if so, we need to stretch it so that we can maintain, again, a normal length to strength relationship. All right, that's it for posture. On to the next one.